Welcome all. I welcome you to the discussion on hemodialysis guidelines in relation to COVID-19. And my name is Dr. Girish and I'll be sharing my screen so that we can have a inside account of what happens to dialysis modalities or dialysis services when it comes to treating patients with COVID-19. And I will be covering this step by step so that we can all have a quick look on the multiple aspects of how COVID-19 is affecting our dialysis services, how they are affecting the health of our dialysis patients, and how best we can deal with the present scenario. So this would be a comprehensive COVID-19 care, and I am Dr. Girish Kumtekar. I work in nephrology, and I'll be dealing with the dialysis patients who have a COVID-19 positive status, and we are involved in the care after the COVID-19 disease is cured. And we also deal with the long-term care of these patients who have an acute kidney injury during their COVID-19 disease. And today we'll be stressing on the guidelines which are presently prevalent with reference to COVID-19. So as this is a very novel virus and we we have still evolving understanding of it. But whatever presently literature we have, I would like to highlight all that we have today, but with very caution that the guidelines may change from time to time as the data comes from multiple studies and multiple centers. So presently, the CKD stage 5D, what we call as dialysis patients, are the vulnerable group because they have multiple issues like diabetes, hypertension, coronary artery disease, malnutrition, hypoproteinemia. And these dialysis dependent patients, they are more likely to catch COVID-19. And moreover, their disease trajectory may be a little different than the general population because these people are already immunosuppressed because of their chronic kidney disease. The most important part I would like to highlight today is that patients who are on regular dialysis should adhere to prescribed schedule and not miss their dialysis session to avoid any emergency dialysis. So a person who is on dialysis and reveals positive status for COVID-19 is not supposed to stop dialysis in between. Their dialysis schedule may be hemodialysis or a peritoneal dialysis should go on the way it was going on. It could be a hemodialysis for twice a week, or hemodialysis for thrice a week, or a peritoneal dialysis for 3-bag exchanges or 4-bag exchanges per day. These things should not be stopped or modified based on the COVID-19 status. They are supposed to be changing day in and day out based on the patient demands. But the dialysis schedule should continue even though the patient is COVID-19 positive. And there are different situations where we face a COVID-19 positivity in dialysis patients that the patient may become COVID positive who was already on a maintenance dialysis. The second situation we may face is that patient requiring dialysis due to acute kidney injury after they catch COVID-19 disease. That means they were not on dialysis before COVID-19, but they go on to develop an acute kidney injury during the disease trajectory of COVID, and they get into acute kidney injury, which requires a dialysis support. Third, patients who are very critically ill, they may need a continuous renal replacement therapy, which is CRRT. So these three things which we face day in and day out when we are dealing with renal problems or kidney problems pertaining to COVID-19 patients. The gold standard question is, should we reuse the filters? In our day-to-day practice, we reuse filters for almost 6 to 12 times. And this is a standard practice, and there is no change in the efficacy of the dialysis. And this is done for quite some period, and this has been standardized. The debate on reuse of filters in COVID-19 has two aspects. One is that the socio-economic status of the patient and the resources the institution has. Presently, as COVID-19 spreads through all over the globe to the low and medium income countries also, we face a scarcity of the logistics like dialysis filters, tubings, and other things. So presently, if the dialysis center is adhering to Army standards of reuse of a filter, and if they are reprocessing the dialysis unit or filter with peracetic acid or hydrogen peroxide and maintaining a good hygiene, reuse of the filters can be done even in COVID positive patients. So at this moment, we should consider the practice of reusing the dialyzer unsafe in suspected or confirmed cases of COVID-19, and considered it as infectious medical waste to be disposed accordingly. So this is the guideline. So when we say that reuse of the filter is recommended for COVID-19, it is only in situations where the logistics are compromised, only in situations where the patient is getting a care in low or medium income countries. But as a guideline, the filter used for a COVID-19 patient has to be treated as infectious medical waste, and it has to be disposed of accordingly as per the guidelines which are prevailing to dispose of a medical waste. So this is the core question to address when we talk about dialysis in COVID-19 patients. Then we talk about first about the acute kidney injury. And the present guideline is that patients admitted in ward of the hospital with AKI should be preferably given bedside dialysis rather than shifting the patient to main dialysis unit. So what we are doing at Symbiosis is we are dialyzing the patients where they are situated. So we take our RO plan to that patient's bedside, we take our dialysis machine to the bedside, and we do dialysis there only, so that the patient is not mixed into non-COVID population. And portable RO reverse osmosis water in a tank will serve the purpose for dialysis. That is what we are doing here. If more dialysis is expected in selected area, dialysis machine may be left in the same area for future dialysis. So what we do, we keep the machine in the ICU, COVID ICU, or by the bedside of the COVID patient who is on dialysis. So we don't bring that machine directly to the main dialysis unit or the negative dialysis. This is what we are doing for patients having acute kidney injury in a COVID positive scenario. And I would like to mention that the incidence of AKI in COVID-19 patients having COVID-19 is somewhere around 5 to 40%. So in worst case scenario, we can have half of the ICU patients admitted having acute kidney injury. So it is up to that extent. So we need to follow all these guidelines meticulously. There are few patients who are extremely sick, who are on multiple life supports, who are in shock, and who are facing the cytokine storm. These are the patients who require the CRRT, the continuous renal replacement therapy. And this is where we need to understand that CRRT machines are freestanding and they can function anywhere in the hospital using sterile replacement fluids and dialyze it. But the cost is quite exuberant. So the cost of a sled and the cost of a CRRT, they are not comparable. But if we talk about efficacy, yes, definitely CRRT will score over sled in these kind of scenarios where we need to remove these cytokines with the help of, say, filters dedicated for cytokine removal like Oxiris or Cytosorb or any other such devices. These extracorporeal therapies using high volume hemofiltration or adsorption to decrease the cytokine level may theoretically be expected to confer some benefits, and they can bring down the cytokine levels, and they contribute to even improving the SOFA score in septic patients. So definitely CRRT will be a preferred modality when it comes to offering dialysis to very sick COVID-19 patients. As I told earlier, the CRRT machines are standalone machines. They can be stationed anywhere in the hospital, and they don't require RO water for their functioning, and they can work with a pre-filled sterile replacement fluid. So the disposal and cleaning of the machine becomes very easy, and that is one more reason we offer a CRRT for very critically ill patients with COVID-19. So this was in hospital dialysis. So what should we do for outpatient hemodialysis? So outpatient hemodialysis, there are preventive strategies to minimize the spread of COVID-19 in the outpatient dialysis setting. So there are multiple patients who are coming to our main dialysis unit for regular hemodialysis. And the aim is to reduce the spread of infection first, and second is optimizing the care of the patients. So how to reduce the spread of infection? We have to active triage and isolation in side rooms of the patients in HD who are suspected to have COVID-19. And the moment we suspect them to have COVID-19, we send an RT-PCR until we get a conclusive report. They are segregated or isolated, and they are asked to wear a mask, a face shield, and when the number of COVID-19 patients coming for outpatient dialysis goes up, what we did, we had a dedicated COVID-19 positive HD unit for all the confirmed cases. So once somebody is suspected to have COVID-19, we isolate, and when the report is confirmed or it's a COVID-19 positive, then we shift the patient to a dedicated COVID-19 positive HD unit. And the patient receives dialysis in that unit till the subsequent report comes COVID-19 negative, the RT-PCR comes negative. And once the RT-PCR is negative, then the patient is allowed to move to the main dialysis unit. And how do we optimize the care? We continue 3 times a week dialysis for all existing patients, and incremental 2 times a week HD for new patients. So whenever we are initiating somebody on dialysis, we do 2 times a week dialysis, and we believe in incremental dialysis, and we step up the dose of dialysis from say 2 times a week to 3 times a week to 4 times a week, based on the patient profile and the patient requirements. And increased physician presence at COVID-19 positive HD unit to monitor the parameters is what we practice. And this is how we need to handle both the units, COVID-19 positive and negative hemodialysis units. The most important thing I would like to highlight is active follow-up of the patient who miss HD sessions. So if somebody is not coming to hemodialysis for their prescribed slot, we call them up, we ring them up, and we ask about their health status. If they show some signs of suspicion or some signs of symptoms coming up, we ask them to get an RT-PCR tested. We dialyze them in isolation area, but we never allow them to miss a hemodialysis session as far as we can, because missing a hemodialysis session in this vulnerable population is going to jeopardize their health with or without COVID. This was about hemodialysis. And about peritoneal dialysis, there are 2 categories of patients mainly seen. Is the patients already on peritoneal dialysis. So somebody who is already on peritoneal dialysis, there is little advantage for these patients because they're already on the home dialysis. So their quarantine, their segregation, their isolation becomes easier than who are coming to the hospital for hemodialysis. And whenever they are tested positive for COVID-19, the used dialysis bag and the tubing should be properly disposed using 1% hypochlorite solution first, and disposed in a sealed bag. And the effluent, what we call as used dialysis fluid, it has to be drained in the flush. so that the drain fluid and the tubings and the connections, they are not exposed to other people. And because of its home dialysis and the patients are already in an isolation, the chances of them getting exposed to infections are lesser than the people who are coming for hemodialysis to the hospital settings, because in hospital, as we know, we may have some kind of infection. Then the second category on the right hand side of the screen, we can have new patients who are planned for CAPD. So initiation of new patients requires a PD catheter placement, admitting to the hospital, doing an incremental dialysis, initial flushings and all that. So in these periods, we sometimes we tell them to get it done with meticulous care. And whenever there is a planned initiation of hemodialysis, with planned initiation of peritoneal dialysis, we are trying to go slow on these patients. And as per the need of the patients, we are doing an incremental dialysis. So probably this may be the way forward for patients where we suspect them to be a vulnerable population to catch COVID-19. The third category, what you can see on the right hand side of the screen, is acute peritoneal dialysis. um, there are multiple papers and multiple people have worked on the possibility of acute peritoneal dialysis in COVID-19 patients, and which has been seen to be life-saving. And it is usually helpful when the hemodialysis facility is not available. Healthcare workers should use all precautions while initiating the acute PD and discard the consumables properly with, say, 1% hyperchloride, or the spending the spend dialysate into the flush and avoiding contact with the biological fluid. So these are the two situations, or I should say three situations where we face COVID-19 in peritoneal dialysis patients. All said and done, peritoneal dialysis may be a good option for COVID-19 patients because it avoids their exposure in hospital setting. But at the same time, we need to educate the caregiver to practice utmost care while doing the exchanges, because not all patients are doing exchanges on their own. There is some family member, some dialysis nurse who comes to their help and changes the bags and does in and out for the peritoneal fluid. For doing this, we tell them to use the personal protective equipment. So while dialyzing COVID-19 positive patients, we need a shoe cover, a gown, a surgical cap, or a hood, or eye shield, maybe a goggle, or a particular mask, and surgical gloves. However, as the life of such masks is approximately 6 to 8 hours, so then can be uncomfortable over a long time and short supply. So preferably the aerosol generating procedures like intubation, open suction, or bronchoscopy, we need to have a surgical triple layer mask, and cloth mask can be used for alternative for all other procedures. So if you are not doing aerosol generating procedure, sometimes double masking may be seen appropriate. But in our setting, we are definitely and strictly following the norms of using an N95 respirator with filters. That is what we are practicing in our unit at Symbiosis. Just look at the other experiences what people had in Western countries. The clinical course and outcomes of 36 patients who were on maintenance hemodialysis was studied. And these 36 patients, they had COVID-19. And out of these, most of the patients had fever, 67%. And almost 22 of 36 patients had bilateral ground gas opacities. And therapies, what was used for these patients was antiviral drugs like lopinavir, ritonavir, hydroxychloroquine, azithromycin, glucocorticoids. Few patients, very less patients, like less than 5% patients, were given the immunomodulator like tocilizumab. And the outcome was uh, pretty comparative to what the outcomes are in countries, our country like India or in Southeast Asia. The discharged patients were 19.5%. The mortality was, say, almost 30%. And what was the predictor of mortality was longer time on HD, increased LDH levels, and lymphocyte counts and 7 days. So these three were the predictors of mortality. And it only tells us that the mortality among HD patients with COVID-19 is very high. And dialysis vintage, lymphopenia, and high LDH. These are markers of poor prognosis. So if you get to see a patient on dialysis who has a long dialysis vintage and who has a lymphopenia, the relative the neutrophil to lymphocyte ratio, and has a high LDH, these are the markers of poor prognosis in dialysis patients. And with this, I would like to again show you the Indian experience. There were 19 major hospitals who gave us the data, and the International Society of Nephrology has compiled it, and under the guidance of Dr. S.K. Agarwal. So the lack of preparedness before the lockdown resulted in an interruption of healthcare services, and that was one of the contributing factors. But as we can say, the deaths are only 0.36%. So actually, Indian dialysis patients or Indian dialysis centers did well or comparatively better than the Western dialysis units. And there are only 2.74% who required emergency dialysis sessions. And there are few patients. I should be more. We all should be more worried about them. Almost 4.13% of patients stopped reporting to dialysis units. So they stopped doing dialysis on their own. And this is the particular group of patients where we need to educate that even though they are COVID positive, they should not be missing their regular dialysis. They can come to the hospital, they can get dialysis in COVID positive unit, and do not stop the dialysis in between without consultation with the physician or the nephrologist. Teleconsultation was started, but accessed by only a small number of patients. So still in India, teleconsultation may not be that useful or may not be that friendly as far as the dialysis patients are concerned. So in a nutshell, what we need to say today is we need to talk about this patient before arriving at the dialysis center or nephrology services. Then we tell them what to do upon arrival at a dialysis unit before the patient enters the treatment area, and what we should be doing while actually managing the patients on dialysis. So when the patients coming before arriving at the dialysis unit, we recommend all sanitary measures or hygienic measures, and we recommend them to measure their body temperature, measure their saturation, and call the dialysis unit in advance to report any signs of fever or respiratory symptoms. So there is some part which has to be played by the family and the patient themselves. When the patient actually comes to the dialysis unit, we need to check them at the arrival. We check their temperature, we check their saturation, we try to maintain a physical distance, and we clearly ask the patients to keep a safe distance from each other, avoid crowded at the entrance, and make sure the patients are wearing masks all the time they are in the hospital, and access all the respiratory signs and symptoms. While actually doing dialysis, we tell the technicians to wear a personal protective equipment to the fullest of its extents. We equipped with a pair of gloves, hat, eye protector, masks, and disposable gowns. And the dialysis stations should be, as far as possible, be kept at least 1 meter apart during the session. So this is something we are working on it because of the number of patients and limited space. Sometimes we may not be able to keep a distance of 1 meter between two patients, but that is something very much doable, and that is what is recommended. And after this, we evaluate the suspicious signs and symptoms of COVID-19. So somebody coming to the main dialysis unit develops some signs or symptoms of COVID-19, we immediately segregate them. We send an RT-PCR, and if they are positive, they are shifted to the COVID-19 positive unit. If they are negative, they are treated according to the physician consult. So how do we summarize? So um, it is a three-pronged approach. One is education, second is screening, and third is management of the patients with symptoms or illness. So these are three-pronged areas. So first we have to educate the patients and the families who are having a vulnerable population at their disposal um, to be careful about the appearance of COVID-19 symptoms, of maintaining the hygiene, training to use mask, so look for the basic signs and symptoms, and also educate the healthcare providers. So, and screening is for all patients. So instruct all patients to call ahead. We ask them to call beforehand while coming to the dialysis unit. Keep checking the temperature. Perform screening test in all dialysis patients. Prioritize testing of dialysis personnel. So those who are actually doing the dialysis. So this is one area where there are differences in guidelines around the world. Although most guidelines are similar, but there are some differences. So we need to accept the guidelines which are appropriate for our settings and which are appropriate for our settings, for our patients and for our healthcare personnel. And to conclude, as this pandemic is spreading all over the globe and we are now at the third wave, or even some people, some places we are at the fourth wave, uh, we need to understand that this is a very much preventable entity in dialysis patients, even though they are immunocompromised. But that needs some extra efforts from the healthcare facility, from the educators, counselors, and the dialysis technicians themselves. And this is all I can tell you in brief about the guidelines for hemodialysis in COVID patients. And this is what I thought was imperative to bring up this particular issue. And I thank you immensely for for giving a priority for this particular topic. And I thank you so much. Thank you so much.